Hello, my name is Ian Adams. I'm a student at Drake University, and today I'm going to be giving a presentation on prolonged exposure therapy. Before I start, just hello to all my classmates out there. I hope you guys are staying safe and sane, healthy. I hope you guys have voted because it's getting dangerously close to the election at the time that I made this recording. But anyway, let's get into prolonged exposure therapy. If I get my slides to work here. All right, so let's hit the outline first. Today I'm going to be talking about the history, the theory behind prolonged exposure therapy, the technique, limitations it has, and future directions. All right, so prolonged exposure therapy has a pretty rich history. It was first developed by Dr. Edna Foa in the late 70s to early 80s. It's a natural progression from exposure therapy, which was a highly effective treatment for phobias and simple anxiety disorders. That's coming from the history of behaviorism and conditioning that people were having to treat anxiety and especially phobias. And you'll see the theme of behaviorism coming up a lot, as well as cognitive therapy. PTSD was not defined until 1980, so this is going kind of way back in comparison to a lot of the very new or seemingly new treatments for trauma that have come up, because trauma is kind of a hot topic, but back in the 80s it was very new. So when the DSM-3 was published in 1980, that was the first real definition of post-traumatic stress disorder. Before then, symptoms were treated like phobias. People generally did not want to talk about trauma back then or the actual event. But then when Vietnam veterans came back, they first tried to do exposure where they were actually bringing the traumatic event back into memory. And what was happening was it was flooding. If you know about just regular exposure therapy, you know that flooding is when you give someone a lot of a stimuli that they're trying to avoid all at once. So they were having them recount those flashbacks in depth, and they were doing it too quickly, and it was actually leading to worse outcomes. So Dr. Edna Foa, who at the time was working with sexual assault victims, which were mostly women, she decided to try it with them in a more prolonged environment. But back then, people didn't want to work with sexual assault victims and rape victims and women in general because they thought of them as more fragile. They didn't want to re-traumatize them or scare them, or they thought that bringing trauma back up to those women would just exacerbate their anxious symptoms. So they generally didn't do that until Edna Foa made prolonged exposure therapy, which was very effective at treating their trauma. Not treating the trauma per se, but reducing the symptoms that they were having, because they found that spreading it out over time and grading the stimuli that they were avoiding in therapy, giving it to them in small doses instead of all at once, things like that were found to be very effective. So that is how prolonged exposure therapy came about. And segue into the theory here. So after this worked, Foa was she became a lot more interested in the structures behind the trauma that these women had. So she collaborated later on in her life and came up with emotional processing theory. So this kind of goes back overall to classical and operant conditioning. That's why it says it was based on decades of behavioral research. So PTSD happens when a traumatic event significantly alters fear structures to the point that a person struggles to function in a non-threatening environment. And this is because the relationship of the traumatic memory to a once neutral stimulus triggers a fear response, overestimating the threat of the situation. So what that means is, as you see kind of on the right, things that would be non-threatening to all of us, to most of us, I should say, like driving on the highway, that isn't logically concerning to most people. But if you have trauma, then that thing has become a very threatening stimulus. It's no longer a neutral stimulus. So that thing is now triggering your fight or flight response when it shouldn't be. And every time this happens, it's strengthening the pathway, but also every time you avoid it, it's strengthening the pathway of, your systems which calm you down. It becomes addictive in a way to avoid those situations, to the point where avoidance is your only way of being mentally safe. So the whole point of emotional processing theory is that you need to habituate the traumatic event, which is supposed to be neutral. You need to habituate that threatening event more and more to the point where it is no longer threatening, which is illogical, and it becomes more logical, and it becomes a neutral meaning, like you see over here on the right. And what FOA found later on, and this is, I might be getting a little bit ahead of myself, but what she found is that it doesn't destroy that pathway before, because people can relapse years later. You can reactivate that pathway that activates your fear response. But what you want to do is to make a competing pathway through all of the graded exposure, through prolonged exposure therapy, to the point where it is much stronger and it will be activated much easier when you have that non-threatening stimulus put in front of you. So that's why people, according to emotional processing theory, become more functional in their environment day to day and reduce those traumatic symptoms, those PTSD symptoms, I should say. All right. Going on to the technique here. If my slides will ever work. All right. Here it is. So there's 3 technical steps to prolonged exposure therapy. And the first, so this is like a kind of running you through what it would actually look like if you were to be a part of this. So the first step is always going to be psychoeducation, which is kind of what I just did with you in a much like an easy to handle type of way. You learn about the structures that are involved in your fear reactions, in your trauma. We talk about the emotional processing theory. You educate your client on that. You might have homework to learn more about it. And then second, you kind of go into imaginal exposure. So you'll be sitting there with your therapist and you will talk literally about your trauma, about the experience. You will record it. You would very often record it. You ease into the process. So what FOA likes to say is that you keep one foot in the past, but you always keep one foot in the present. So you're doing things to make sure that you're still there with the therapist and you aren't back in your trauma, like you are doing some mindfulness things. They wouldn't call it that back in the 80s per se, maybe. But you're doing some mindfulness things to make sure that you are still there with the therapist and you know that you're not actually there in your trauma. And this is usually the things that turns people off from prolonged exposure therapy. Is it can be extremely hard to have that first experience of sharing your trauma and going back when you've been constantly avoiding it and you've been constantly building that pathway of avoidance. So you're going to recount your trauma. You're going to talk about how you're feeling. You're going to talk about what you felt back then, what you're feeling now when you're recounting it. And you're just going to keep doing that. You do that day after day after day, every session. And every day you might get homework to listen to that recording. Listen to that recording and maybe jot down how you're feeling when you're listening to the recording, when you're listening to yourself recount your trauma. And then eventually the goal is in vivo exposure. The third step, I should say, maybe not the goal, but a part of the process is in vivo exposure, where you actually go out into a situation that might trigger those fight or flight responses. You are there in that situation that is threatening to you, illogically, but it's still threatening to you. So maybe you go into a supermarket. Maybe at first you go into a supermarket that's crowded. Say you're afraid of crowds. Maybe your first step in your in vivo exposure means that you go to a supermarket at 10 a.m. when there are very little amount of people there. And eventually you're going to build up to the point where you go there during rush supermarket hours, like at 4 p.m. and you go and shop, and you might have someone with you. You might have your therapist with you. You might have a trusted friend or family member with you, but eventually you want to be able to do that by yourself. And the theory, which we've already talked about, has I've already stated, has shown that this habituation process will lead to a reduction of symptoms, elimination of dysfunctional behavior, that avoidance behavior, and the extinction of the fear mechanisms, so they're no longer being triggered in your normal day-to-day life. Before this, I'm saying it shows that interoceptive exposure can take place during the last two phases. Interoceptive exposure was added a little bit later, but basically it is a form of exposure where you remember what your body was doing when you experienced the trauma. So say you were in that situation and you were out of breath. You were in a war situation where you were sprinting for your life. You were scared. You were out of breath. You felt like you were dying. What you can do in the office or even in vivo, in real life, is you can get your body to that point where your heart's racing, you're out of breath, you feel like you're hyperventilating, or whatever it is. You can do that in a safe environment with the therapist or with a trusted individual. Well, maybe not with a trusted individual, but definitely with a therapist. And you can recount your trauma then. And that can be very powerful in learning, well, this is how my body is feeling. This is completely normal. I'm experiencing something that was threatening, and I'm not experiencing harm to myself. You can eventually learn to habituate, again, those feelings to the point where it's no longer threatening to you. The entire process is dynamic, which means that you can go through one step faster than another step. Some therapists may not do as much psychoeducation. Some therapists may even leave in vivo exposure as a part of the goal outside of therapy, where you might not do that with the therapist. But it's completely dynamic. But it usually takes about 3 months of weekly 90-minute sessions. All right, so I'm going to learn a little bit more about habituation since I've said it a bunch of times. So it's a key part of both exposure and prolonged exposure therapy. It's the process of creating a competing pathway, like I've said, that overtakes the dysfunctional fear pathway in strength by having prolonged and non-threatening exposure to the feared stimulus. And by the end of the therapy, and this was kind of really important that Foa noted, the goal is not to forget that the traumatic event happened, but to be able to remember it and not trigger a fear response. So a lot of people coming into therapy, they think, I'm going to get rid of that traumatic memory, or these people are going to help me repress this memory. And that's not true. The thing is, you can have the memory, but you know it's in the past, and the past stays in the past. It happened, but it doesn't have to affect you now. And it doesn't have to make you scared now and make you feel anxious now. And habituation is the way that you get there. This is classified in two different ways. There's within session habituation, which is when anxiety is reduced over time of prolonged exposure to the feared stimulus within the session. That means that during that prolonged exposure of talking through your trauma repeatedly, over that one instance of talking through your trauma, from beginning, you start at a certain anxiety point, and at the end of that story, you are at a lower anxiety point, hopefully. So that is habituation within session. Between session habituation is your anxiety symptoms are reduced from session to session over time. So both of these things obviously are going to be trending downwards. If the therapy works, it almost always trends downwards. At the beginning of telling your trauma, you're going to be very anxious. And at the end of the traumatic story, you're going to be less anxious. And between sessions, you're going to be less anxious. So this is their kind of measures to find that prolonged exposure therapy was effective. All right, next slide here. I believe this is limitations. All right, cool. So limitations. Prolonged exposure therapy has the most empirical support of any treatment for PTSD. And this was up to a meta-analysis made in 2018. But clinicians are often hesitant to use it. I don't know if I have a source for this, but I remember reading that I think it was the reason I didn't use it as a source was it was like in 2004, but they like polled everyone in Britain, every counselor in Britain, and they found that, or I think it was clinicians, they found that only 17% of people were using PE, prolonged exposure, and they asked them why, and a few of the reasons were there was a fear of re-traumatization and exacerbation of symptoms, which persisted from the 80s, which was it was found to not be true. That's kind of the black and white of it. And clinicians fear that comorbidity contradicts PE's use, and that was kind of this is also untrue. But a lot of people worry, a lot of clinicians worry that someone comes in with complex PTSD, so they don't just have PTSD, but they have substance abuse. They have like very acute suicidality. They have, bipolar. They have a borderline personality. All these different things, and they thought that we can't make this person because they have such complex trauma. So much complex PTSD, so many things could go wrong, and I don't want to re-traumatize them. I don't want to bring up their trauma because who knows how they're going to act, But a example I would like to bring up for that kind of fear is Chris Kyle, which is right above me there. So Chris Kyle is not a trained counselor. He had, and unfortunately, this is kind of what has happened in the modern world, is a lot of people that are not trained think that they know how to reduce trauma symptoms. And I'm not saying that Chris Kyle was a bad guy or he had harmful intentions in doing that, but he brought a friend to a shooting range to try to treat his PTSD. And that person had psychosis, active psychosis. And that person ended up basically just shooting Chris Kyle and his friend that were trying to help the guy. The guy was a veteran. He had PTSD, and he thought that bringing him to the shooting range would help him treat that. But obviously, I think that's kind of the fear that goes into the mind of a counselor in treating PTSD with an exposure therapy. I think it is a lot of fear. I think there's a lot of fear of liability. If I was a counselor, this is just me guessing. But it kind of has to go back to the counselor needs to be confident and know that this treatment does work. It is old. It seems archaic to just reintroduce trauma back to a person, but it is extremely efficacious. It is still, like I said, up to 2018, still found to be the most empirical support out of any trauma treatment. But I do understand the fear there. Newer models, which are quicker as well as easier on both the counselor and the client, are gaining popularity. Everybody else's presentations, which have been great, most of them are things that are relatively new, and I'm not saying that they don't work. In fact, I'm a huge fan of a lot of the different treatments for trauma. I'm just saying that they haven't been around quite as long, and they don't have as much research because they're so new. So a lot of those treatments might not bring up the trauma, or you might have ways of avoiding the trauma, or just separating the content from the feelings and just attacking the feelings and not recounting the trauma. There's no exposure. Those are a lot easier on the counselor, and they're a lot easier on the client. And a lot of the times they're a lot faster, and sometimes there's research to support, although it's new and might not be the best research, it supports it. So a lot of people don't really, if they find a better alternative, they don't really want to have an exposure therapy because it's so tough to bring up that trauma and not know what someone is going to react to it. So I think that most counselors are scared to be a Chris Kyle, when really there's a lot of differences between Chris Kyle and a trained counselor that's in a very safe environment. All right. So future directions. So we're going to watch a little video about virtual reality exposure therapy, which is VRET. It's kind of new on the block, as you might expect. It uses virtual reality headsets to treat PTSD. So let's go ahead and watch the old video, and I'll mute myself.
There is such a growing demand for mental health services. All the while, the number of providers in the world has remained relatively flat. My name is John Sotkel. I'm co-founder and COO of Limbix. We make apps and VR for treating mental health disorders. We chose virtual reality because we saw probably 20 years worth of research, maybe 300 peer-reviewed publications that had showed VR play some sort of meaningful role within mental health care. Within cognitive behavioral therapy, there's a technique called exposure therapy. And exposure therapy is the idea of flooding someone with the thing that causes them distress. So a really simple example could be if you're afraid to drive or couldn't get behind the wheel.
So this is the Limbix headset.
Once that therapist knows that you're ready and comfortable to do this exposure, the therapist might start you off on a quiet street. And so you're in your virtual reality headset as a patient. And as the therapist next to me, as I'm going through this as a patient, all the while sees what I see in VR on their tablet.
What we have here is the tablet interface.
And on that tablet, they can choose that quiet street. They can also choose a busy road like a highway or a tunnel or something much more anxiety-inducing like a bridge. And so the therapist will slowly but surely gradually expose me to more and more stressful environments. And then while I'm viewing these and going through that therapist is also teaching me coping techniques to be more comfortable with what I'm doing and things that I can apply to my own life when I'm actually in the car afterwards. There's much more serious examples around PTSD and other phobias as well, where exposure therapy can be really helpful.
It's the 21st century exposure therapy. It's as close as you can get to real life without going into real life, and the data shows that it works as well as going into real life. So for therapists, it's a beautiful tool.
It's critically important, we think, to take them through a rigorous FDA process. The alternative that people have done to date is basically making direct-to-consumer apps. You don't want to send people on their own at home to do things that could potentially make them worse. And so in the last couple of years, the FDA has rolled out a new therapeutic class called prescription digital therapeutics. And basically, the FDA is now attempting to evaluate apps the same way that they evaluate drugs. Make sure that the apps that doctors and others are providing have some sort of basis of evidence that they work. But really, it's about trying to provide lots of access for lots of different problems, because ultimately we want to make these treatments available around the world. I think the way we improve access to these treatments is with cost-effective technology that can be democratized around the world.
Thanks for watching. If you like this video, give it a like and subscribe.
All right. Like and subscribe, guys. Okay, so there's a lot to take in from that video. He did say at one point where the VR tech would flood the person with information, and I think that might be a slight misuse of exposure therapy. In prolonged exposure therapy, you typically don't want to flood someone. You want to make sure that you build trust by grading the exposure. So you might use VR between imaginal and in vivo, for instance, and that's not really flooding. That is a graded exposure. So flooding is if I sat you down first time and I said, okay, you're scared of crowds, get up and we're going to go to the mall. That would be flooding, which is not typically safe. And there's some instances with a phobia it might be effective, but it's generally, I don't think you'd want to use that for someone with really bad PTSD. I happen to know a little bit about VR.
Subscribe to Free Think Now.
Oops, my bad. Can we go to the next slide without playing? All right, so I know a little bit about VR. This is a complete humble brag. Oh my God, I'm wearing the same sweater. I didn't even notice that. Damn. All right, sorry. I'm sorry for that. It's a nice sweater, okay? So I really genuinely did not notice that. I have the same haircut too. Just need to ditch the glasses. I did a lot of VR research. I tested a lot of mostly memory exercises. We didn't do a lot of counseling, but what we were finding was people are generally reactionary when it comes to VR. Either they take it as a complete joke and they don't take it seriously, or they become very immersed in it, and that's kind of scales. The people who take it as a joke perform as a complete outlier, so you kind of have to throw them out. They'll just get like everything wrong, or the people that are very immersed in the environment and take it seriously do very well in all of the experiments. So I'm just speaking anecdotally, but I think that there's a lot of genuineness missing from VR right now, and what you can do and how much you can personalize someone's trauma. So for example, running a veteran through a generic war game might be kind of a joke to them. They might not take it seriously. It might not help them. In fact, it may even hurt them. Trying to get them to kind of associate war with action in that video game. So I think that there's a long way to go for virtual reality to be put into a counseling situation. I definitely think it can be beneficial. I think that it has a lot of issues right now, not just limited to the technology, but limited to people's acceptance and openness to the technology. But definitely I could see a world where you didn't even have to put on a headset. You can go into a room and experience that real social phobia you may have, experience wartime, have that as close to in vivo as humanly possible. When technology gets to that point, I really believe that VR can really help a lot of people. Okay, so I think that was the end. I went a little bit over my time. Here's my references. Again, I just want to say, hope everybody's being safe. Hope everybody is healthy. Hope everybody is voted, because you may have watched this after Election Day, and if you haven't voted, then you're out of luck. That's terrible. I'm just kidding. I'm not going to judge you, but I hope you vote. If you're watching this before Election Day and you have not voted, please vote. Stay healthy, stay safe, stay sane, and eventually maybe we'll see each other in person at some point in our lives. All right. Thank you guys so much for watching.